You guys will just let me know if there's a problem, because obviously once I put the presentation up, I can't see you clearly because I'll just see the slides. So you'll just obviously put on your mic if there's a sound issue or something is frozen on your side, eh? You guys will
Bongi, can I leave it up to you, please?
Once I put the presentation up, I can't see you clearly because I'll just see the slides. So you'll just obviously put on your mic if there's a sound issue. It's frozen on your side, eh? You guys, Bongi, can I leave it up to you, please? Once I put the presentation up, I can't see you clearly.
Why is there a delay in repeating what I'm saying?
So you just obviously put on your mic if
Did you all have that delay?
Yeah.
Yes.
That was weird.
Okay, hopefully it's fixed.
all have that delay.
Yeah.
Yes.
That was weird.
It's happening again. It's repeating.
Okay,
Wait, let me undo this mic.
Can I start the webinar now?
All have that.
Just hold on, my dear.
yeah.
Yes.
That was weird.
Yes. I'm starting the webinar.
It's happening again.
Can you still hear me?
Repeating.
I've taken the mic off. Maybe it's the mic.
Can I start the webinar now?
All have that. Just hold on, my dear.
Yeah. Are we starting?
I'm ready.
Okay.
Can we start now?
Yes.
Okay.
Good evening and welcome to today's SADA and SASPIO Oral Health Month webinar. I'm Dr. Sibongile Mahlangu, and most people know me by Dr. Bongi. I'll be hosting this evening's webinar. So we have our guest speaker tonight, who is Dr. Bradley Bredekamp, whom I will introduce later. We have partnered up as SASPIO with Colgate for this webinar and this Oral Health Month. And we will have Buisile Oliphant from Colgate, who's going to give us a introduction. Over to you, Buisile.
Thank you, Doctor. Good evening, delegates. A very warm welcome to everybody. As Doctor has said, am Buisile Oliphant, and I am the oral care consultant for the region of KZN. I'm very pleased to welcome everybody to today's webinar, especially being in September. As we all know, September is Oral Health Month, and this month highlights our shared vision, making our collaboration with SADA and SASPIO all the more special. Before I go on, I'd like to thank Dr. Bredekamp for taking the time to prepare and present on tonight's webinar. We really do appreciate it. As Colgate, we are committed to supporting your professional and your growth in working with you and advancing healthcare in South Africa. And we really hope that these educational initiatives are beneficial and take us a step closer to bridging the gap. However, before we kickstart the evening and we get onto the learning, I would like to share a short video on the new Colgate Total Active Prevention.
Prevention is power. Colgate Total's new prevention technology fights dental plaque, the root cause of many common oral health issues, helping stop those problems before they start. To fight dental plaque, many formulas use stannous fluoride. Powerful but highly unstable, it can degrade quickly, reducing the toothpaste's effectiveness over time. Unlike others, Colgate Total's patented technology stabilizes stannous fluoride using a novel combination of 2 known ingredients for 3 key benefits. 1. High bioavailable level of the stannous active. 2. Long-lasting efficacy. And 3. Enables customized formulas through sensory science for specific needs. Colgate Total's new prevention technology. Preventative, powerful, and patented science that helps fight the root cause of many oral health problems.
Thank you, Dr. Wungi. Over to you.
Thank you so much. I'd like to now proceed and introduce Dr. Bradley Bredekamp, who will be giving us a talk on periodontal plastic surgery. So a short CV of Dr. Bredekamp. He is a specialist in periodontal and implant dentistry, working between KZN and England. He prides himself on clinical expertise, ongoing dedication to academic advancement, and an honest, empathetic approach to care. With over 2 decades of experience in advanced training in oral medicine, surgery, and implant planning, Dr. Bredekamp has helped countless patients restore their health, function, and quality of life, especially in cases where others couldn't. Beyond his clinical work, he's passionate about educating patients and mentoring colleagues. He believes that when knowledge is shared, standard rises and everyone benefits. His famous quote is that treating the problem is only part of the work, helping the patient understand what caused it and how to prevent it from happening again. That's where the real change happens. Over to you, Dr. Bredekamp.
Thank you, Bongi. From my side, firstly, let me just say thank you to Dr. Suzette Stander from SASPIO and SADA for the invitation to come and talk to you tonight. Thank you to Marlies doing all the behind-the-scenes work, and then thank you to you, the attendees, for sacrificing your Tuesday evening to come and listen to me for an hour talk to you. I'm going to, let me just share my slide. Okay, I hope that's working. Okay. So for those of you who don't know me, a little bit about myself. As you heard, I'm Bradley. Everybody calls me Bradley. I've been a periodontist for over 20 years. As you can see on the look of my face, I practice out of Durban, South Africa. This is where we are in Ridge Road. Practice we've moved to about a year ago, and the practice is called Periozone, where I work closely with my partner and associate and partner in crime, Dr. Bongi Mshlangu, who you just heard from this morning. Another important part of my life is being closely associated with the Implant and Aesthetic Academy based in Cape Town, where I've had the privilege to lecture, teach, and share the platform with, in my opinion, some of the smartest and most innovative minds in dentistry. We've got guys like Dr. Rian Wolfart on the left here, is one of the top general dentists that I've seen. Dr. Jonathan Dutoye. We've got Dr. Rudy Garano. Many of you know who I would classify as the rock star of implant dentistry. And Dr. Willie Ritz, Suzette Stander, and many others. And when you work in this environment, it sort of forces you to raise your game. And I think in South Africa, we don't often realize or appreciate how fortunate we are with the clinicians at our disposal. If you look at implant dentistry, for example, and you look at South Africa, I don't know if you know these people. The first guy is Dr. Miguel Stanley, head of the White Clinic in Portugal. Then we've got Dr. Costa Nicolopoulos, maxillofacial extraordinaire out of Dubai with the same day implant clinic. We've got Dr. David Garbo, who was probably one of the best prosthodontists in the world from Team Atlanta. You've got Paulo Maulo, who invented the concept of all-on-4, all-on-6 that's been taking the world by storm, especially the last few years. And then our very own Dr. Howard Gluckman. And why do I mention these guys? Because all of these guys were born in South Africa, and they become of the leading guys in the world in their fields. So we are fortunate to have that. We are fortunate to have institutions like the Academy and others. There are quite a few others that want to teach on your doorstep, because many people have to spend lots of money and travel abroad to go learn. And we've got some of the top guys in the world, as you can see, that are from South Africa. So that's enough about where I'm from and what I do. I've been asked to talk a bit about periodontal plastic surgery. So periodontal plastic surgery was first coined by Paul Smuckler in 1993, and it's a broad spectrum that deals with surgeries related to aesthetics largely, that can involve the hard and soft tissue, okay? But this encompasses a lot. Just some examples: you can do gingival recession. The treatment of gingival recession will fall under periodontal plastic surgery. There's crown lengthening. It could be functional crown lengthening, as you see in that picture, to expose more tooth structure for a crown. It can be cosmetic crown lengthening, where people have gummy smiles and we're trying to reduce the gummy smiles. We can have vestibuloplasty, like this case that I saw recently, where there was not much of a vestibule and she needs an implant. And so we had to correct that first with some periodontal plastic surgery to create a vestibule and give us more keratinized tissue. There's soft tissue augmentation, which can be free tissue or can be pedicle grafts, either to increase the thickness of the tissue or volume. We can have things like frenectomies, things like deep pigmentation. There's cases with attached keratinized tissue increase, especially around implants where we need more of that. And then even when we have some issues with implant aesthetics and we need soft tissue correction to try and close it. So these are just some of the more common examples of all the different procedures that can fall under the umbrella of periodontal plastic surgery. So you can appreciate that it's not possible for me to speak for an hour on all of these. In fact, I can speak most probably on an hour on every single one of these, at least. So I thought to myself, well, if I'm talking to general practitioners, what is the most common thing that you would encounter with regards to patients that need some form of periodontal plastic surgery? And for me, it's gingival recession. So for the most part of the next 45 minutes or so, I want to speak on gingival recession, and from a general dental perspective, how do you manage that? I'm going to keep it quite basic as much as I can, because I want to speak to that dentist that's young or new or doesn't deal with others, that gets the patient in, that will learn something hopefully from what I have to say. Because often patients come to me and they say, oh, my dentist said I'm going to lose my tooth, or it's because I brushed too hard. And while those largely may have been true in some cases, it's not the most common causes, and it's not always what needs to be said to the patient. So let's say you have a patient like this that comes to your practice tomorrow. What do you do in a case like this? Okay, how would you approach this case? Hopefully, I'll give you some food for thought that you will now have a better understanding of the options and what you should say to the patient at the end of the next 45 minutes. So let's start off first by explaining what is gingival recession. So according to the American Academy of Periodontology, they've classified gingival recession as the apical displacement of the tissue from the cemento-enamel junction. Now, what this tells us is that the cemento-enamel junction is a very important or critical landmark when it comes to dealing with recession. And it's not only important in defining it, it's also important in how we treat it, and you'll see later. And don't forget that. But there are two terms that are commonly used when we deal with these kind of recessions. The one is recession, And the other one is clinical attachment loss. You know, as a periodontist, we like to be pedantic with some of these things, but I want to explain to you. So with regards to recession, as we said, it's basically the apical position or the dropping tissue from the cemento enamel junction to the free gingival margin. Okay. Clinical attachment loss is again from the cemento enamel junction, so the same reference point, but to the base of the pocket. So that would tell you how deep the pocket would be if the patient hadn't had recession. But for the purpose of tonight's discussion, we're going to focus on recession specifically. Okay, so I come back to my question. What do you do in a case like this? Historically, what we've done is we've put on fillings. You can see this is a 76-year-old gentleman I saw last year, and you can see just various examples. He's got amalgam fillings, and he's got composite restorations. And this is how we used to do it in the day. And it's a testament to these treatments that in this guy, it still lasts after all of these years. But is this the best way to treat it? And in today's day and age, this wouldn't be. And why? It wouldn't be because it's not aesthetic, right? The world is obsessed with aesthetics. Everything is about aesthetics. It must look aesthetic. So what is aesthetics? According to this publication in 2009, in the International Journal of Periodontics and Restorative Dentistry by two of the main guys in research, Stephen Chu, Dennis Tarnow, these are big names. They defined aesthetic dentistry. They say patients are looking for natural looking teeth and gingival architecture within the aesthetic zone. So it must look natural. Okay, that's what everybody is after. So let's give you an example. You have a cavity like this in the tooth, an occlusal cavity. Would you think that's a good restoration? It may seal the margins, but you wouldn't think that that's very aesthetic. Would you think this is more aesthetic than that? Many would say yes, it is, but it's still a silver filling on the occlusal. But most would say that this is the best way to restore it. It's the most aesthetic. So why is the second one, the middle one, better than the first one? Because they're both silver fillings, but the middle one has anatomy carved into it. So anatomy is where it is tending towards the natural occurrence of things. Why is the lowest one better than the others? Because not only does it have anatomy, but it's got the same color that the tooth should be. So this is an example of why we find in our own mind's eye, we find the lowest one the most aesthetic, because it is the most natural looking form to what we're accustomed to, right? That's what we will choose. So when we look at recession, it's not natural for a tooth to show so much of the root. If you look at the teeth on either side of the tooth, they are more natural looking, and therefore they become more aesthetic. And that is the essence of when we treat it to some people, if aesthetics is what we're looking for. If it's just function, then obviously things are different. And hopefully I'll explain that. So again, what do we do in a case like this? Well, the first question is, must we always treat recession? And if you look at the literature, it says, no, you don't always have to treat recession. There are indications for the management of recession, whether it be surgical or non-surgical. So sometimes you can leave recession alone. Okay, so if we accept that, then the question is, we can monitor it or we can treat it. I'm going to focus more on the surgical aspect, although that's not the only one. So let's first look at monitoring. How do we monitor this recession? Okay. This was a publication in Periodontology 2000, which is regarded as the dental journal with the highest impact factor. So why am I mentioning this? Because we like to say we are evidence-based, but you can find the evidence for almost anything in the literature if you look hard enough. So when we look at the literature, we generally look at journals that are very strict in their requirements. They are very well edited and researched, and the studies are of high quality. That's called impact factor. How often they are cited. Okay, the impact factor. Then we also look at the authors, and generally the guys who are main authors or publish a lot that are well-renowned are guys who are more, I wouldn't say trustworthy, but they are more reputable, and therefore their data has higher value than somebody who's a no-name brand or hasn't done much research, just for those who don't understand how these things work. So according to Mary John in Periodontology 2000, when do you monitor? When there's no evidence of progression of the recession, so it doesn't seem to be getting worse. But in order to do that, you have to have a baseline where you've seen the patient first time and then follow them on. So when you're seeing a patient for the very first time, depending on how severe or the other complaints of the patient, you could say to them, well, let's just monitor it for a while and then decide. When the clinical attachment loss, as I mentioned, to the base of the pocket is less than 5 millimeters, or when the recession is less than 2, which basically means the same if the pocket is a normal up to 3 millimeters deep. And when you have all of the above, but the teeth do not require subgingival restorations or orthodontic treatment. If they require orthodontic treatment because the orthodontics will generally make the recession worse, then you may be compelled to get in there and correct that first. So how can we monitor it? Photography, very important. But when you do photography, you need to make sure that you've got good, clear, direct vision, 90-degree picture of it, so that when you put a picture alongside it, similar to your X-ray principles, you can visually see if there's a difference or not. Okay, obviously a high quality camera, and these days your smartphones can be decent cameras. So you can use them if you don't have one of these SLR cameras. Obviously, if you're lecturing, then they may not always be good enough. Another way to measure is by probing. But the problem with this, if you look at the one on the right, sorry, the pictures aren't clear, I got this over the internet. The one on the right is what we call the WHO probe. So it's got a band from 3.5 to 5.5. Now, if your recession is changing by half a millimeter or millimeter, then that probe is not going to give you that distinct difference that you can measure. The Williams marking, which is the one on the left, with the 1 millimeter is a bit better, but even that may not be good enough if you're having small increments of recession change. So the best are like digital calipers that you can actually measure to fractions of a millimeter to compare if there's a change or not, but most of us don't have this. Another important tool these days are our intraoral scanners, because the intraoral scanners allow us to record it and keep a record of that. And then when we scan later on, we can compare. Okay. This is just a study that was published out of Bristol University in the UK, where they were, as a proof of concept, they were showing that the algorithms and the AI and the quality of the scanners are developing to such an extent these days that you could actually diagnose gingival health just based on an intraoral scan. I don't think we're there yet, but it's an indication of where things are heading. Imagine you can just scan them out and it'll tell you whether the patient's got gingivitis and how severe the gingivitis is if you're scoring. Okay. Some intraoral scanners, like the 3Shape, this is from Howard Gluckman, will actually allow you to, over time look at the progression of change. This is when it's been corrected. So you can actually see it. And the value of something like this is you can actually show the patient how it's getting worse if it's the opposite direction, and then they may be more inclined to want to do something about it. Okay, so these are ways in which we monitor, if we're going to monitor. So let's say we decide we have to treat. Why would we decide to treat? One is for aesthetics, because the patient isn't happy with it, and generally that's more related to the upper teeth. It can be symptomatic or a combination of the two, because there's exposure of the root surface, so the patients are having a lot of sensitivity, and they don't want that. Like I said before, if you're going to have orthodontic therapy, because the orthodontics may aggravate the recession, and you need to make the patient understand this, so they don't complain afterwards that it's worse and we just blame the orthodontist. Or when the exposed root surface is predisposed to pathology like root surface caries. So these are all indications to treat. Now, how do we treat it if we decide to treat it? So again, in this publication in the Journal of Periodontology in 2020 by Leandro Chambroni from South America, they divided the treatment into 3 pillars. Okay. The first pillar, they said, is you need to identify and control the causative agent. What is causing the recession? And this is where you as general dentist, most of you, if you are general dentist watching, where you play the biggest role in the management. Even if the patient is going to need surgical correction, you still need to be involved. So what are causative factors? Again, according to Mary John, the primary causative factors are either plaque, mechanical abrasion or removal, so the physical thing by toothbrushing, for example, and to a less extent, thermal or chemical injury. Okay. Then you get susceptibility factors. So what are these? These are factors that are not directly the cause, but if the patient has this, then it's going to increase their chance of having recession or getting worse. Thin phenotypes or biotypes, example. Other recession areas already, very little attached keratinized tissue, deep probing depths beyond the mucogingival junction, and a history of progressive recession and previous period disease. Okay, so when a patient has all of these, not guaranteed they are going to have recession, but they've got a greater chance than somebody who doesn't. Then the third thing is modifiable conditions. So what are modifiable conditions? These are conditions that have not been shown to have a direct cause and effect relationship, but things that you can help control the patient with. So they're often associated with the recession, even though it hasn't been proven that they directly cause it. Okay, and you are able to modify it. And the importance of knowing these factors is because these are the factors when you're consulting with the patient that you can explain to them they need to work on to reduce the risk of the recession recurring again. An example of these are like a frenum position. So they may need to have a frenectomy, but you need to make them understand that the frenectomy on its own is not going to stop, because I often see some guys say, I'll just do a frenectomy. But that's not going to correct the recession. It may stop it from progressing further in a fast rate, but it's not always going to stop it, because if the patient is a brux, it may get worse. So it's an adjunct. Okay. Things like a shallow vestibule because of the muscle pull. So you need to correct that. You also poor brushing techniques. This is the one everybody tells patients all the time, but it's actually one of the least common causes of recession if you look at some of the studies. Yet we think it's the most important. And then orthodontic tooth movement. It's a big factor, as we know. Often we see patients after orthodontic therapy that's had recession. Now, it's very important when you look at the recession like this that you distinguish between toothbrushing from trauma or actually from occlusal forces. When patients have these lesions from occlusal forces, and we'll touch a bit more on it at the end, towards the end, these are called non-carious cervical lesions or abfraction lesions. They have a very sharp margin to them. This is not usually from toothbrushing. Toothbrushing tends to be smoother, rounded margins. So if the patient has this, then you need to check the occlusion. Now, there has been debate in the past about whether occlusion causes this, but that is changing. We can also pick these up on our intraoral scans these days. We can see these abfraction lesions and we can show it to the patient. Another reason why the intraoral scanner is such a valuable tool, and it's become an indispensable tool for me in my practice. Okay, so if we look at this study was published in 2020, where they looked at, they used finite element analysis, and they looked at the occlusal load, and they checked on the tooth where was the highest occlusal load stress on the tooth, and they found that in bruxism patients, it was at the cervical margin, at the neck of the tooth. So there's a strong correlation now between occlusal load and these abfraction lesion shearing. So there's more and more evidence to suggest that this is the cause of trauma. This was a study published again in the Journal of Prosthetic Dentistry in 2016. Very good impact factor journal, often cited. And what they did was interesting. They did a prospective study where they followed patients up over 5 years. They used the T-scan, I'll show you that now, and they checked the occlusal load, and then they looked at different factors such as diet, medical health, toothbrushing technique, other bad habits, and occlusal load. And they found that the only factor that correlated with the progression of the recession was actually occlusal load, the bruxing. That was toothbrushing didn't have a significant impact on it. Neither did diet or other habits. It was actually occlusal load that had the only significant factor that played. So we need to monitor the occlusal load. This is the T-scan device. It's almost like an articulating paper, and it gives you the high stress points. I'm not an expert on this, but I'm obviously aware of it. It is quite expensive, but not expensive as some of the others. But what you must understand, and what I find a lot of dentists miss, is we sit with the patient and we take the articulating paper and we have them bite and chew, and we look at the colors, whether it's red or blue, and we grind away. But many of us don't appreciate that very often that is not the patient's natural bite. There was a study done in Turin, Italy many years ago where they link people up to electroencephalograms for the brain, and they use different words like bite, chew, grind, close, and different centers were activated, and the masticatory muscles were used in different degrees and different muscles. And so the whole bite is changed. So here you go and you grind because you only have that piece of paper to give you guidance, but the patient's not doing a natural bite. They then go home, they relax, their natural bite kicks in, and the crown breaks or something changes, and you think, but I checked the occlusion. Yes, you checked the occlusion, but what your reference was incorrect. So you need to be aware of that. And that's why often you have to go with temporary restoration so that the patient can test it, and then you can come back and adjust accordingly. There is new technology that's newer technology, been out for quite a while now, that is important. I'm going to exit this quickly because the video doesn't work if I do that, to show you this. So this is called the mod jaw for those of you who haven't seen it. So it's a series of sensors you put onto the patient's mouth and forehead, and then you get a special camera. And what it does is you give the patient something to chew, and they're chewing like a peanut or chewing gum and so forth. And it actually records the jaw movement. And you can now take that and you can then incorporate it into your exocad system, and it'll on your articulator, and it'll reproduce the patient's natural chewing ability. So that is now where we're becoming more accurate in assessing the occlusion. The problem at the moment is, I think the last time I checked, this thing is like $50,000 US, so it's over R1 million. There are companies coming out with similar. I think Shining is coming out with something similar, but this is where the industry is headed. And once we get this right, then I think you can see there it does the jaw and articulator. Once I think we get this right, it'll help us a lot in having less issues with the occlusion. Okay, but we're not there yet. And unfortunately, they're giving her a sweet there to chew, and you can see how, because the patient then can't fake. They can't, not that they're trying to fake it, but they're going to chew a piece of thing like they normally would chew, and it gives you that. Okay, so the point I'm trying to make here is, if you've identified that the patient has got an occlusal issue and that's contributing to the recession, then you need to address that occlusion, because if you don't, then the chance is greater that they're going to have relapse. And please, when you make a night guard or occlusal splint or whatever you want to call it, it needs to be a hard acrylic. It mustn't be a soft rubbery thing, because you make it, and I see a lot of guys make it because it's more comfortable for the patient, but that's going to encourage the patient to chew more, to grind more, because the whole purpose of this thing is to function. The analogy I use to patients is, if you're chewing a chicken sandwich and you bite on a bone, before you realize it, your teeth stop. Because the minute you eat that hard thing, it stops, because the brain is saying you're going to break. If you're giving it something chewy to work on, then they're going to grind even more because it encourages them. So you need to make this and address it and manage it before you then do the further steps of managing the recession for the patient. So that speaks to how we identify and control the causative agents of the recession. The second pillar that we have is we need to now assess the characteristics of the defect and their surrounding tissue, the nature of the defect that we're going to have. Look at the features. So again, you can see I use my intraoral scanner. This patient was referred to me because of the recession on the 2-1. And I took an intraoral scan. But the interesting thing, you can see they had this type of Maryland temporary thing stuck on. Notice how they've already fractured it over here. Okay. Notice how they've got recession on the other teeth in the second quadrant posterior. So on the right side, you can see there's quite tight contact. That's good. Decent occlusal spread. Not so much recession as bad on this side. But if you turn it to the other side, look on the left-hand side, look how much more recession there is. But look how poor the occlusal contact is on the side. Besides a tooth missing, so that's the other reason they were referred, there's poor occlusal contact. Now, this is information I'm gathering because of my intraoral scan. This was the old version, so gum doesn't look as nice and shiny. But I want to show you, when I look at this closely, look at the poor contacts that the patient has on it. There's no contact between the canines. There's no contact here. So there's only contact on this 2-1, a little bit on the 5, and all the other contact is on the 7, occlusal contact. Look at the gap that's there between that pontic, okay? And when with most of our intraoral scanners these days, it doesn't matter which one you use, you can actually assess the occlusion as though you've used articulating paper. And if we do that over here and we open up the patient's bite, then we can see that there's very little contact on these premolars. It's on the molar. Look at the molar. Very little. There's nothing there because it doesn't oppose me. There's very little there. And there's load here on the front. So what's happening is that front central incisor is taking a lot of the forward pressure, which is why there's recession occurring. If we take the understanding of the studies I've just mentioned before, where they show that the occlusal load is related to the recession, then there is an explanation. So if I go and I correct that recession surgically, for example, but I keep this occlusal scheme as it is, the chance is great I'm going to have relapse and my recession is going to occur again. It's also why you can see on the right side, there isn't as much recession because the occlusal scheme is more balanced. So while we're looking at recession as what the patient is coming for, let's say hypothetically, I can't zoom in and just focus on the recession. As a dentist, it's my duty to analyze the whole occlusal scheme. I need to make this patient understand that if I fix your recession, but we haven't fixed your occlusion, not only is it going to recur, the recession going to recur, but there's a greater chance they're going to fracture more teeth. And you can see there's already fracturing happening. So that's one aspect of the surrounding structure. Okay, look at the occlusion. The other thing we look at is we look at the recession itself. How much tissue have we got left? Is it keratinized? Is it non-keratinized? We've got a shallow vestibule. Have we got the tooth standing too proud, as in this case? Especially with lower canines, if it's too prominent, then the likelihood of my recession recurring or my treatment not working is higher. What about the loss interproximally? Because if I've lost the tissue interproximally, then I'm not going to get this recession back to where it was. Okay, I cannot get that. It's impossible. You can be the best periodontist in the world. You're not going to do that. So you need to look at all these things to understand. And the other important thing you need to look at is you need to look at your CBCTs, because you need to determine if you've got bone on the buccal of those lower teeth. If the bone is at the apex, then you may get some gain of if you do surgical correction, but you're not going to get all the gain. And so the patient needs to understand that, because if they're paying you for surgery, they're expecting it to look perfect. So you need to manage that expectation, but you need to diagnose the tissue around to determine how successful it's going to be. This is why Preston Miller in 1985 came up with the Miller's classification. And while the classification is flawed in many ways, you must understand that this was based at a time when the only treatment of choice for a patient dealing with recession was a free gingival graft. That was all we really had. So what he tried to do is he tried to classify what is the likelihood of success if you did a free gingival graft. So what he said was, A class 1 is where there's recession that is not extending to the mucogingival junction. Again, remember that's between the attached gingiva and the alveolar mucosa. And you've got your interproximal tissue intact. So in a case like this, you've got a 100% chance of getting success with the free graft. Class 2 is where it extends to or just be beyond the mucogingival junction, but the interproximal tissue is intact. Still good chance of success, 100% in most cases. Class 3 is now where you've got it to or beyond the mucogingival junction, but you've lost some of the interproximal tissue. So now you're not going to get 100% success, that's for certain, but you'll get some. And then class 4 is where there's whole collapse of the tissue. Okay, and that's not likely to be successful. But this is to try and help us. There have been other classifications subsequently. That's not the purpose of this lecture. I'm just making you aware because often people still use the Miller's classification, and it's still the most common way to explain to guys how bad it is. But remember, the purpose of this was to show whether a free gingival graft works. So we've identified the cause and we've managed it. We look at the characteristic natures of the defect, and now we come to what is the most suitable treatment option for the patient. Okay, and I'm going to speak more from a surgical perspective. Not that I'm saying it's always surgical. There are non-surgical ways to manage it sometimes. But from a surgical perspective, we must, even in surgery, there's not one surgery. There are multiple options, and I'll show you some and how we decide. So we start with the free gingival graft because this was the first way we treated it. This is that same case I showed you in the beginning, like how do we treat it? So I did a free gingival graft, I covered it. But what you must understand now that you know the purpose of Preston Miller's classification was when we do a free gingival graft, there is no blood supply over the root surface. So because of that, we are relying on the blood supply from the surrounding tissue. And that blood supply needs to be sufficient to be able to supply vascularity to that green zone. Otherwise, that tissue is going to die. So generally, we try and make as big an area as possible. But obviously, in the lower jaw, we're limited especially to the adjacent teeth because we can't just take a tissue away from there because the minute we cut there and we do surgery, we run the risk of causing recession in those areas. Okay. The problem with the free gingival graft, as you can see here, so I don't get coverage on that root surface, not much at least, but I've got my attached keratinized tissue here, which is supposed to be reduce the risk, reduce the risk of the recession progressing. Okay, that's the purpose we're telling the patient. But sometimes we get great results. This is a case done by Bongi. As you can see, look how much coverage of the root there is. But the problem is when we get this, we end up with poor aesthetics. Why? Because remember, the pink color of the tissue comes from the vascularity underneath, because the light reflects off the blood vessels in the subepithelial tissue, because remember, epithelium doesn't have blood vessels. And the thicker that barrier of epithelial tissue, the less light reflects and the paler it looks. So we don't have great aesthetics, even though we've got good coverage. This is another case done by my good friend, Dr. Willie Ritz. Beautiful case. He asked me to follow up. Look at that lovely tissue there, but it's not aesthetic. Okay. So therefore, we don't do free grafts generally, except in the lower anterior mandible, because people don't often show it there. But where we generally do it also, even in the anterior mandible, is in cases like this, where we have very little vestibule. So if you look closely, you can see there's not much height to work there. So what some guys do, they just do a frenectomy. Doing a frenectomy here is not going to solve the problem because you've got muscular attachment here too. So in these cases, we tend to do a free graft. Sometimes, even though we're going to do another surgery after like a coronal advancement, we still do a free graft because we need to create a vestibule. So we go with something like this. As you can see, look how little space we got there. To that, look how much more we've gained now. Sometimes we are fortunate and the tissue does creep up. It doesn't, but we've got more space to work. Here's another case. Obviously, we cleaned his teeth before we did the surgery, but you can see this is what he presented. Sorry about all the air bubbles. And look how much we've gained afterwards. There's the free graft in height. You can see the teeth have been cleaned. This is a week post-op. Okay. But when we're dealing with the anterior maxilla, it becomes more of a problem, because when people smile, especially they've got a very high smile line, they're not going to want a pale chunk of gum there that looks different to the others. So free gingival graft is not the treatment of choice there. So in those kind of cases, we tend to, one of the options we employ is more what we call a coronal advanced flap or coronally repositioned flap. This is the modified one done, proposed by Giovanni Zucchelli, who's one of the world authorities on soft tissue surgery. There's a specific formula we follow. There's a specific way we separate that. I'm not going to go into the detail of how we do this, but we raise the flap. We then harvest the tissue from the palate. We deepithelialize it. There's a good technique we use for that as well. We then suture that into the area. We've now got a technique we've been using that we've been trying out. I've done lots of cases, I know Howard's done lots of cases where patients don't have pain afterwards. I mean, it used to be a very painful procedure to do, but we now have a technique where patients complain of hardly any pain, and so the acceptance of the treatment is much higher. But we then advance the tissue. There's a position we advance to, according to Penny Prato, and that's what we end up with. So we go from that to that, which, as you can see, is a much more aesthetic outcome, and we've got good root coverage. This was a 35-year-old lady I did, but you can see much better. You can even do it in full arch cases. This is a case that Howard did. You can see, following the same principles, we raise the flap in a certain way, following the same formula that we worked out before. We release it in the same way for a single, just doing it for multiples. Deepithelialize the area, release the flap, graft a bigger piece of tissue, suture it down. There's a way we suture it, reposition it, and look at the end result that we've got for that case. Beautiful end result. Okay, so there is treatment that we can do. The problem with the coronal advanced flap, though, is that sometimes we still get scarring. You can see over here slight scarring from the releasing incisions. Even though some people claim that you don't get scarring of gingival tissue, you can get scarring of gingival tissue. Not severe, but it can be. You've seen apicectomy sites afterwards as well. So it can be a problem, and therefore that's not always the treatment of choice. So come along with tunneling technique. This wasn't founded or discovered by the Otto Zur and Markus Herzler, but they are the two main guys, the German periodontists, who really made this become mainstream in the acceptance of it. So what do we do here? We do special incisions in the sulcus, and then just in the sulcus, and then we use special instruments, and we release it. But we have to use special blades. It's not normal. I'll come to that later. This is a variation of a tunneling that was developed by Anton Sculian. This was, I think, published in 2017, I think, or 18, I can't remember exactly. But for those of you who were at last year's SADA conference in Pretoria, he was one of the guest speakers, and he had a nice workshop on this. So what he does is he teaches you the technique where you do the same principle, tunnel around there, and do a graft over there, and you can close it up. So remember this case that I showed you? This I did before his course even. We did the free graft, remember? And that's what we ended up. But the patient wanted a bit more coverage. So I said, look, I got a bit more vestibule now. I can do a tunneling. Again, never promise them they'll get it perfect, especially the first time. Sometimes you need multiple surgeries. But she was keen to do it. We then went from there, released the tissue, did my connective tissue graft. It needs to be white in color, not yellow. That's another thing we teach you. Put it in the area, sutured it up, closed like that. And we went from there to there. That was 3 weeks later. Significant improvement, still a bit of recession there. I'm trying to get her back, but she's been traveling a lot and immigrated. So I'm hoping to get her back because there will be still some creep, and I'd love to see that. But you can see if you compare that amount of root exposure to that even immediately post-operatively, or a week post-operatively, there's a big improvement. So this technique has merit in it. But when you're doing these techniques, you need to know you've got to use special instruments. You've got to use the MJK blades, the bendable blades. They're expensive blades, but you need to know you've got to use your tunneling instruments. Let's let them have them. You can get from your dental companies. And there's a way you release it. But very important when you're doing these type of surgeries, you must follow the microsurgical technique. So this was published already in 2005 by Rhino Burkhardt and Nicholas Lang. And what they did is they used microsurgery and macrosurgery. And this is an angiogram, just to explain to you, if you look at this picture. So what's happening is on the top, they use the macrosurgery. So that's the big instruments, the sutures, 4O, 3O sutures. And the bottom is where they use micro instruments, thin sutures, magnification. Now, where it's dark, it's dead. There's lack of vascularity. So this is at the time the flap was repositioned on the left, and on the right, it's a weak post-surgery. Look how much blood supply is here compared to that half, more than half of that flap is still dead. Okay. So what they just showed in their publication is when you use microsurgical techniques, you have up to 50% better outcome and better healing. So if you're going to do these kind of procedures, you have to do microsurgery. So what is microsurgery? There are 4 aspects of microsurgery. You have to use magnification, you have to use illumination, you have to use the right instrumentation, and you have to use the right sutures. Again, I'm not going to go into detail with this. We do it in the academy, but you need to be aware of it. Cortellini and Tonetti in 2014 stated that the use of microsurgical instruments together with magnifying aids became a standard way of performing periodontal plastic surgery. So that is the standard. If you want to do periodontal plastic surgery, you have to do microsurgery. You cannot do it with macrosurgery. It is now the standard. Okay. So these are instruments we use. There's AdSense tissue holders or tissue tweezers. There's Castroviejo. There's the micro blades that we use. So we don't use your 15C, even that's too big. We use the micro blades. You get the Viper, you get the spoon, the MJK ones, because you can bend them. Okay. And Zucchelli also says that soft tissue handling is the most crucial for the success. If you want to have success in this, if you want the graft to work, you have to treat the tissue properly. Suturing is important. We do not use braided sutures. We only use monofilament. We do not use 3O, 4O, even 5O sutures. We use 6O suture as the thickest. Some use even 8O sutures. And if you want to use 8O sutures, you have to use a microscope. 6O, you can maybe still get away with a loop, but you need magnification. Okay. You need to use a 3/8 round needle, 12 millimeter, 13 millimeter maximum, and it must be reverse cutting. Again, you must know the tools you got to use to get the right result. So put it to the test. So these are pictures that Howard took. So what he did was, if you see on as you're looking at the screen on the left-hand side, he used 6O monofilament suture in the same patient in a surgical site. On the right side, he used 5O suture. Look a week later, look how little scarring there is. Look at this. Now you may say, yeah, okay, but maybe the flap moved and all that. Possible. Look 2 weeks later. Look at the difference in the healing. So then he takes it one step further. He takes a different patient. This is what we call the Marius Steichmann's aesthetic buccal flap that is done here. Same site, not the same patient, now same patient, but same wound, and half of it with the 6O suture, half of it with the 5O suture. Look at the difference a week later. Look, you can hardly even see the incision line. Why? Because the vascularity, as I showed you from that study from Lang and them, there's more vascularity there. You're not strangling the tissue, so the healing is better. 2 weeks later, look at this healing versus this healing. If the publications show you something and you practice it and in your hands you find the same outcome, then there is a lot of stock to be taken into those publications, and you can see it here for yourself. So I'm not just telling you this, it's proven, and I've seen it time and time again. So the tunneling technique is a good technique. There are different ways we suture it. This is a case I did a couple of years ago. This is another case that I did more recently. I think it was last year. I'll show you this case. So you can see this is she's a ballerina, if I remember correctly. She had all this recession, wasn't aesthetic, so I wouldn't do a free graft. We went and we did the tunneling because we didn't want to create releasing incisions in the area. Sutured it up. That's 1 week later. 1 month later, she went from that to that. I'd say that's a good outcome. I made a mistake here, though, and I'll show you later, because I'm not only going to show you that I do everything right. Look at this 2-3. See, the recession was too much here, but if you do that, and the length there, it's not far off from there. So we should have restored it first, but I did it after. It's not the end of the world, but I should have done it first, and I'll show you this case later on. This is another case, this is a very old case, sorry, that's why the photos look so crap, but this is a patient 3 years later. You can see it's stable. It didn't recur after 3 years. So it is a good treatment option that you can do, that if you've managed all the other things, if the occlusion needs to be managed, then you can get success. This is another extreme case done by my other good friend, Dr. Rudy Garana, the rock star of periodontology. Look at these abfraction lesions. Okay, this is bruxism that's caused all of this. So what he's done is he's done the tunneling technique because he didn't want to show any releasing incision scarring. Did his connective tissue graft in there. You can just see it sticking out there. You can see it sticking out there. And look at the beautiful result he's achieved here. Stunning. I'm not sure I could get it to look as good as this, but it's beautiful. His photography is also next level. So these are surgical techniques we can do. But those, what you saw in this case here, to go back, these are what we call non-carious cervical lesions, for those of you who haven't heard of it. It's not root caries. So it's not caries, right? So what are non-carious cervical lesions? This is a publication published in 2020 by a group from Belgium. It's a very nice article where they explain to you. So non-carious cervical lesions are the result of pathological conditions where there's loss of tooth structure at the CEJ, but it's not related to dental caries. So it generally relates to usually bruxism or trauma. There's a high prevalence, okay? You can see wide range from 5 to 85%. And they tend to have very characteristic shape, like very sharp lines and wedge-shaped things. So it used to be debated whether it was related to occlusal load. Like I said to you early on, more and more the evidence seems to suggest that that is more the case, that is becoming more and more established that it's occlusal load that contributes to this. So what most guys do is, even the guys who do a very good job at this, they would restore, close it up with filling. What most of you would do is put a composite filling in there. Is that the right thing to do? Yes and no. So what do I mean by that? So what they say is that part of the thing must be restored. And if you do the restoration, as you can read here on the top blue line, the restoration must be placed prior to the surgical procedure, because you have better visibility of the operative field and you can finish the restoration. So not afterwards. So that case I showed you, which I'll come to again later, the ballerina lady, we should have done the restoration first. But why is it important to do the restoration first also? Not just for that. Remember I said to you that when we look at treating the recession, our reference point is the cemento enamel junction. So we need to know where the cemento enamel junction is. So this publication, again by Giovanni Zucchelli, in 2011 already said that he classified different kinds of defects and how you treat it. So what he said was, if you look here, is, excuse me, if you've got a non-carious cervical lesion, an abfraction lesion, you need to determine where the cemento enamel junction must be. And then you need to restore the tooth only to that cemento enamel junction. Now, some of you may be a bit shocked by this, that we're saying this. So what he's saying is, if you have a case like this B, so the red is the whole defect, but the original position, the cemento enamel junction is there, just above the arrows I'm looking. So the gum, when it's in its ideal position, covers the whole defect, then you mustn't put a restoration in that defect. You graft the whole thing with soft tissue, because some of the tissue doesn't attach to most of these restorations. So you have a weakness there. So you cover the whole thing with soft tissue. Don't fold it up. Okay? If you have it where the position of the gum should be, let's say, halfway, like in D, between halfway of the defect, then you only fill the half of the defect with your restoration. Polish it, you use your rubber dam, polish it up, finish it off nicely, and then you refer to your periodontist, and then they need to move the tissue to just above that CEJ and fill that with connective tissue. If the gingiva needs to lie at the base of the defect, then you fill the whole thing up with the restoration, because that's where the CEJ must be. I hope that's clear. So in a case like this, it happens that, okay, this is where the tooth must be, the CEJ must be, so then you fill the whole thing up with soft tissue as Rudy did. But if it was supposed to be over here, halfway, then you would restore it to halfway and then refer for the graft. Okay, that's what it essentially says. And obviously, you've got to follow the principles of isolation and all that, which I'm not going to lecture you. I'm not an expert to lecture you on that by any means. Okay. So I hope that's clear. So here's this lady we did it afterwards, and I sent it to a dentist, Dr. Kevin Naidu in Belito, and I think he did a brilliant job. Look how nicely it looks. She's over the moon. Okay. But what I would normally do now is I would actually first refer her to restore that, and then I'll pull the tissue. Not always makes it, doesn't always have to make a difference. So let's look at this case of Rudy's, like I said before. So the question to ask is that where the CEJ must be? Where the green line is? That's possible. Or should the CEJ be where the blue line is? Because remember, I need to know where that is, because that's going to determine where I'm going to advance my soft tissue to once you've created that. So how would I know where it must be? Well, that determines what the length of the tooth must be. And the best way to do that is by DSD, Digital Smile Design. So again, for those of you who aren't aware of it, what is Digital Smile Design? Digital Smile Design is a concept that was developed by Dr. Christian Coachman. And what he said is most people look at the mouth when they look at the teeth, and you end up with these unnatural looking restorations, whereas you need to look at the face, okay? And when you look at the face, you determine the proportion of the teeth. This was a farmer that I did, and we do a mock-up first. So we send it to the planning center if you have access to them. Now, I have to make a strong point here. There are a lot of people claiming to do DSD out there. I've seen it on social media, and they're not doing DSD properly. There are a lot of labs claiming to do DSD, and they're not doing DSD properly. There's a difference between digital smile design done properly and just a digital wax up. Okay? And I'll just briefly touch on that. But this guy, we do a mock-up. So all we've done is we haven't touched his teeth. We've done the planning, the design, and then we put it onto his existing teeth. So this is what he looks like before. We haven't touched his teeth. And this is what he looks like with the mock-up in place. And you can see big difference. That's my reference. Sometimes it can be, this is another 70-year-old lady. Sometimes it's not that dramatic, although it's noticeable. She didn't want it done. And then when she saw the end result, she was, oh my goodness, I want that done. This is another more extreme case. You can see, look at the difference it does to the face when you do the mock-up. But the DSD is not just doing that. What they do is they plan the pre and post-op, where they look at the length of the teeth. They then give you the measurements per tooth individually if you need to reduce the gingival tissue to crown lengthening and how much you need to add on. But they don't only do that. They look at the incisal slope and the overjet and overbite and calculate that. And then they do an occlusal analysis, and they look at the occlusal analysis. Because if you're just going to look at the aesthetics and lengthen the teeth and the occlusion isn't right, it's going to fail and it's going to break, and you're going to get frustrated because you haven't done the occlusion. So if you want to know more about DSD and how to do it, you need to go listen to guys like Mark Bowes and John van Lierop. And they teach these things where they teach you. And you need to go and do I think you can still do it online with Christian Coachman, the residency program, and educate yourself in how to do this properly. because you can change the way you practice dentistry. This was a case sent to me recently by my good friend Dr. Yusuf in England. And he shows me, he says to me, "Hi Brad, can you do any magic with this?" And why I put this up is to show you that we don't need magic. You can see, so in a case like this, what would we do? Take this whole chunk of, this is what most guys would do, or many guys would do, just put a whole blob of composite on there. No, what you should be doing is working out where the CEJ would be. I would say there where my arrow is. Restore it up until that point, polish it, finish it off. Remember, it has to be highly polished and finished. Don't just do a blob like this. And once you've done that, then what I would have done is I would do a Scullion lateral tunneling technique, graft and close it up and get result. I haven't seen this patient yet. We can also apply these same principles to dental implants. This is a patient that smokes, and he's a heavy smoker, not perfect result, but he had this after years. We did a graft and connective tissue, and we ended up covering most of it. Okay, so we can apply these to dental implants as well. Don't forget, there are other skills you also need to learn, such as the biologically oriented preparation technique, which can also help encourage some of the downgrowth tissue. These are where you don't have margins. Again, it's not going to solve, you can't apply it to the same thing, but when you're doing cases and you need crown bridge work and we've advanced it, then this is another tool. If you can do this technique where you won't let the tissue recede again, where it helps to creep them up, but you need to learn these. I've just shown you one aspect of how we manage it from a surgical point of view. If you're interested in learning this, I'm going to do a little punt here for the Implant and Aesthetic Academy. You see we do a lot of courses over there. They're usually sold out because as far as I'm aware, the Implant and Aesthetic Academy is the only place in South Africa which teaches you soft tissue procedures and how to utilize. I may be wrong, but as far as I'm aware, we're the only ones that show you how to do soft tissue surgery, and it's a good skill to try and acquire. Okay, so if you're interested, you can take a screenshot of a scan code, or you can email Laura, who's the lady who deals with all the bookings at the Implant Aesthetic Academy. There won't be a course in the soft tissue, I think, till next year, so you've got time. You can speak to her, find out where, and then we can do it. Okay, so in conclusion for me, please, I hope I've enlightened you a little bit on how we go about managing these cases. I hope you've seen that I get a patient coming to me, my dentist said for years, there's nothing that can be done, you got to live with it. Why did I not know about this? Hopefully, if you're one of those, you now realize there are things that can be done. I also hope that you realize that it's not a case of just sending it off to the periodontist and let them do their surgery. There's a role to be played by you as the restorative person to establish the scenario that allows us to achieve success if you've managed the issues that you need to manage correctly so that we can have a greater chance of success. And if we work together to do that, we can change the cases like that and convert them to successes like this. And with that, I thank you for your attention. And I'm open to take questions, Bongi.
Yes. Thank you very much, Dr. Bredekamp. I'm now going to look at the Q&A, and there are some questions that have been posted here. So firstly, I'll read this statement. It says, Dr. Bredekamp, thanks for the very informative lecture. So the first question is, what can you do periodontally to reduce dark triangles?
That's an interesting question because there isn't one answer or one solution. Remember, it depends on how big the triangles are. And I know you say periodontally because most often if they're very large, you'll have to have long contact areas so that it closes the space. Sometimes we can do some grafting and we would do an advancement. There's a suturing technique by Hertzler called the reverse cross suture, which pulls it down. But if you've lost a large part of your papilla, then no, we're not going to get that right periodontally. Unfortunately, you have to rely on restorative options to improve the situation. So it's very difficult for me to say because it's a case by case. If you've got large triangles, then and you've lost a lot of bone, then the only way to try and correct that is restoratively. I hope I've answered your question.
Okay, so off to the next question. In a case where a patient presents with sensitivity due to CEJ exposure, however, there's no visible recession clinically, how do we treat or approach the scenario?
Good question. So surgical correction would not be my first port of call for a patient like this. You can, because if you're saying that you're not seeing any recession, then the question is, where is the sensitivity coming from? So the only thing I can think of is, because if the dentine isn't exposed, the root isn't exposed, then it could be interproximally. So I'm assuming you're talking about a virgin tooth. If the tooth has restorations on it, then you need to look at the restorations if they've got leaking margins. If the tooth is a virgin tooth, then I would start with desensitizing agents first and see if that makes a difference before I do anything else. I would also correct like I said, correct the occlusion, manage that first, because again, if they're bruxing, it could be transient and that could be causing some of the recession because of the tissue moving. Make sure they again, periodontally healthy, because if they've got some deep pocketing and periodontal disease and it flaps open, then that can also cause recession, even though it doesn't show, the CEJ isn't exposed. So you have to look at all these scenarios and then identify what is the best. And you have to work by process of elimination, starting with the least invasive and then working your way up. So surgery would definitely be my last resort, because if you don't have the CEJ exposed, then doing surgery is a waste, because the surgery by nature will cause shrinkage of the wound, and then you may have worse recession because of it.
Okay, thank you very much. So that was the last question, and the other comments are mainly thanking you for the fantastic lecture, very brilliant and informative.
Thank you, Rona.
lecture.
Rona's our other periodontist in KZN. So thank you, Rona. Appreciate the feedback. And to Dr. Crick.
Yes. So thank you so much, Dr. Bredekamp, for that lecture. I believe that everyone has a take-home message from this lecture. It is very broad, and I think you've tried to cover most aspects of perioplastic, but mainly focusing on gingival recession. And like Dr. Bredekamp has mentioned, that perioplastic is a very broad, it's an umbrella term to cover most of the procedures that we perform as periodontists, and gingival recession is just one aspect. So thank you so much, and can everyone have a great evening.
From my side, thank you everybody for listening to me. I hope I didn't finish too late for you. Enjoy the rest of your evening, and hopefully I see you all at the SADA conference in the near future. Good night.
Yes. Okay. Sorry, man. There's a few questions that just popped in now.
Okay.
I'm do not mind. Okay. Can abrasion and recession go together?
Yes, for sure they can. You can have
Alright.
abrasions and you can have affections, and there's not just one way. So yes, you can have abrasion, lesions, and recession as well. Not as
Alright.
common as abfraction, but yes, it can.
Okay, the next question is,
Sorry, let me just add, and obviously if it's abrasive, then you need to manage the toothbrushing or the habit, things like that. And it's less of managing the occlusion if you're certain that it's the abrasion that's causing the issue.
yes, thank you very much. And this next question, which is something that does occur very commonly. So the advice for a patient who had orthodontic treatment has lower anterior fixed lingual wire, and there's recession now on a lower anteriors.
So what I would say is, if the patient has had orthodontics and they've had recession lower anterior and it doesn't bother the patient, so they're not sensitive, it's aesthetic, obviously, so usually it's not an aesthetic concern, you can monitor the situation, but make the patient aware that there's recession. We can say we can monitor it first. So you can, like I showed you, whether it's measuring, whether it's photographs, whether it's your intraoral scan, tell the patient, let's review you in a year's time. This is now obviously the patient who doesn't have a concern with the recession. And if it isn't progressing, then you monitor the patient. If the patient has issues with it, it's sensitive, they don't like the look, or you see it's progressing, then I would assess the cause. Take a CBCT, see what the likelihood of it is, because if the whole tooth is outside the envelope, then the likelihood of good recession success is not great. You can increase the thickness to minimize recession, but remember, the patient must understand they're not going to get full coverage. And if you've managed the occlusion and it's stable and the patient's oral hygiene is good and so forth, then you can refer the patient to a periodontist to then manage further and correct it. And as a periodontist, I would appreciate it if a dentist has gone through those steps, because it shows me you know what's going on and how to manage it. And then we have a greater chance of success for the patient. I wouldn't take the wire off if they can keep it clean, though, because that wire, like I said, when we're suturing, it's helpful. In fact, I did a case yesterday on an ENT surgeon where we used the lingual retainer to sling the suture on to help keep the tissue up. So don't take that off, please.
All right. And then the last question is, many patients cannot afford expensive perio surgery. Would a class 5 filling be adequate to address the severe sensitivity?
Look, I think firstly you need to educate the patient as to their options, because you mustn't make the assumption they can't afford it, because the surgery need not be as expensive as you may think. Secondly, you can do class 5 fillings, but what you must remember is once you do that filling, unless you finish it off well, it can be a plaque trap, so that can aggravate the situation. The second thing is, if the patient later on decides that they want to have perio surgery, then we have to remove that filling or part of it to establish it, and then there's extra work. So yes, I mean, there are a lot of dentists doing class 5 fillings all the time. I'm not suddenly saying you cannot do that. What I'm trying to educate you as a general practitioner is that should not be the standard treatment of care necessarily for every recession case. That you need to understand there are other options, and that you just need to make the patient aware of it, and then they can decide how important it is for them to do that. Because so often I get patients that have come to me and they said, but I've been to other dentists and they all said nothing can be done, and now you've done something about it. What's wrong? And then the dentists are saying that look like they don't know what's going on, which is not what we're trying to do. We're trying to educate you so that you're aware. But yes, you can do class 5 restorations, as long as you do them properly with isolation, rubber dam, polish, finish it off, which I also don't see a lot of guys doing. I see very rough, uneven, not polished restorations, and that's not good, because that's going to become plaque traps and aggravate the situation.
Okay. Thank you so much. That was the last question.
I better go before more questions pop up, eh? No, if you have any other questions or you're too shy, you're welcome to send me a message or mail me. If you need my details, you can get it from Dr. Suzette Stander, or you can forward it through the academy and we'll deal with it. Okay. Thank you, everybody, for your time. Have a good evening. Goodbye.
Thanks, bye.